We promised you today a webinar around remote care reimbursement. And my name's Brendan McCauley. We are ChroniccareIQ. I'm joined by Matt Ethington, our founder and CEO today. And our goal is to really arm you with information that will allow you to go back to your offices, your practices, and really envision what a remote care strategy might look like for your office. And importantly, how that remote care strategy will affect your performance in engaging patients, improving on quality and value, and also generating new revenue, largely for work that you're most likely already doing in your practice. Much of what we'll cover today, you'll see, is time-based codes. So my name again is Brendan McCauley. I'm one of our vice presidents here, and I'm joined by Matt Ethington, our CEO and founder, and we are ChroniccareIQ. We have some very, I would say, straightforward attempts today to help you understand what the future of value-based care might look like and what the future of the new normal might look like right now. So what will we cover today? The 2020 final rule added new codes and adjustments to previous rules, which are very attractive for chronic care management, remote patient monitoring, and as I'll explain to you, there are new codes available for specialists who manage specific chronic conditions. And the case for chronic care management, transitional care management, PCM, which is principal care management, and RPM will be made. And many of you are familiar with the triple aim, now colloquially called the quadruple aim. And its case study, basically, that goal is of the triple aim was value, basically, better quality, lower costs, improved satisfaction, but now it includes physician and clinical employee satisfaction. And the reimbursements for non-face-to-face activities will be a significant focus of today. How they are attained, who does what does the workflow look like, how much is on the table from CMS for you to be reimbursed. We'll also take a look at a brief case study and a use case example using discharged cardiac patients. And we'll take a look at how this workflow actually works for surveilling patients remotely, and how do we capture the billing time, and what is involved in engaging those patients. And ultimately, how can ChroniccareIQ help you in this new normal? You know, prior to COVID-19, going back to 2015, there were codes available for reimbursement for chronic care management. And what you'll see through the unveiling of some of these codes today is that CMS has doubled down quite a bit on the success that they've seen in saving money to Medicare, as well as connecting with patients in between visits for the purpose of improving on quality outcomes, which is highly pertinent to the quality payment program, no matter what track you may be in. So let's just take a look in the rearview mirror just briefly, because again, prior to COVID-19, it may have seemed like a new activity or a highly administrative approach to managing patients. However, I think a light has been shined at this point on the fact that waiting for a patient to end up at the ER, or waiting for a patient to even come to the office and sit in their car and wait to have their blood pressure taken, or to be screened, or to be asked certain questions by their provider, to keep them in a state of wellness is something that's not going to be as efficient as interacting with those patients remotely. Many seniors now are sequestered from their families, and they are living on their technology via email or their cell phone, their smartphone. And what CMS is showing in this image published by Mathematica is that from 2014 to 2016, significant amount of money was saved to CMS as a result of doing chronic care management, and that hospital services, skilled nursing facilities, outpatient services, and total medical expenditures dropped significantly as a result of doting on patients in between visits. And I think it's fair to say that most people would agree that patients with chronic disease, they manage their disease by themselves rather poorly in between visits. And that's where costs skyrocket and wellness and those trips to the ER become more and more profound for families. that are helping a loved one live with chronic disease. So this should really be no secret, but I do present it to you today because while we're living in a post-COVID world or a COVID world now, there certainly is enough evidence prior to this that this should be an approach that helps chronic patients stay out of the hospital. And now, more than ever, we want to make sure that we don't expose patients unnecessarily to chronic disease, as well as COVID, for example. Now, the quadruple aim is worth mentioning because if you are involved in MIPS or an APM or you're involved in an ACO, like some of you I know are, you have pressure points around performing. And very simply put, we want to try to help you perform in the quadruple aim through remote care and connected care. This now might seem like a no-brainer given the COVID state of America, but even prior to that, there was a significant push by institutes of healthcare quality and transformation entities to help primary care and specialists to perform in quality and value. And connecting with patients remotely has been proven to have the effect of improving outcomes, lowering costs, and improving the clinician and patient experience, whether it's transitional care management, chronic care management, or remote patient monitoring. These types of activities have the result of helping move a patient from the denominator to the numerator and lower their costs. And CMS has couched this as connected care. There are reimbursements, which are important to you now, because a lot of this work you're probably already trying to do. You're trying to do TCM, or you're trying to reach patients after a non-elective event in the hospital where they've been discharged, or you're trying to reach patients who have a chronic disease that you know needs your intervention. And CMS has been offering these reimbursements for a while now, but they are more and more every single year as CMS realizes that it's actually helping them save money. So chronic care management now has these several codes, and what's new is they added on an add-on code that you can do up to twice a month. And what's important to note is that these codes, for the exception of TCM, transitional care management, are all based on time. So how you capture this time that you spend with patients remotely is how you get billed. And that's what you'll see in the chronic care workflow that we have today. Remote patient monitoring has been an area known as RPM, which has been expanded upon. CMS actually couches it as chronic care remote physiologic monitoring, looking at patients and their data that they have either generated themselves or that has been sent to you from a device. And these first two codes here, 5.3 and 5.4, revolve around devices that will send data to a provider, and whereas 5.7 and 5.8 are really all about interactive communication with a patient remotely in between visits, and they pay quite handsomely for 20 minutes of time. Principal care management is about 30 minutes of time, and there's two codes, one for physician time of 30 minutes and one for staff time. And again, that was the focus for specialists really who might be managing a specific condition. And of course, there are virtual check-ins that we help facilitate that can also be done through telehealth. But this is not a telehealth webinar today. Remote patient management, chronic care management, principal care management, these are key things that remunerate monthly under general supervision and do not require direct supervision by a caregiver. And that's why they're actually quite lucrative, because your staff is most likely doing these things already. You just need that mesh to help capture these things. And then you need to have a way to engage those patients with technology remotely, which is what ChroniccareIQ does. So I want to run through just a quick understanding of these codes and work RVUs. Transitional care management, code 99495, is for moderate complexity and requires that you have a call that initiates contact with the patient within 2 business days. And if you have a visit within a calendar period, 14 days, you'll be paid the lesser of the 2 TCM codes, which is about $165, depending on where you live. The CPT code 99496 is about more higher complex patients, and it would revolve around a non-elective event and a patient being discharged. And you would want to know about that discharge, and we will help you know about that discharge so that you can reach out to that patient And within 7 days of that discharge, you have to have them in the office for a visit. And this is, again, something CMS saw as highly valuable to care and to lowering cost and increasing quality. And what's important that CMS has actually taken the step to remove the barriers that you currently could bill for TCM and CCM, but previously you could not. This is a new addition to the 2020 final rule, which is quite significant because most people do want to do TCM and CCM to be able to manage those chronic patients that are discharged from a non-elective event. And there is a CMS fact sheet on TCM, but the TCM reimbursement is based on patients having a certain amount of complexity. So it's not the case that you would simply bill for TCM if an otherwise healthy 65-year-old happens to break their wrist playing tennis and is in for observation and then released. That would not be a good example. CMS wants you to use discretion and reasonableness in this code. Chronic care management, there's significant add-ons. They started off as one code, and I think people had in their mind the myth that you had to hire a call center to keep someone on the phone for 20 minutes to get $42. And that's simply not the case. The new incremental add-on code shows that it's expected that there are a number of interactive, behind-the-scenes things which occur to take care of that patient's disease, whether it's RX refills, lab sign-offs, interaction with a referring physician. And every 20 minutes, up to doing it 2 times, is billable in a calendar month. And that's significant work RVU, and it's also a significant reimbursement for the practice for work mostly already occurring. Remote physiologic monitoring also has grown in the 2020 final rule to include code 99458, which allows for additional time of 20 minutes for a caregiver and staff during the month. So time that is spent reviewing patient-generated health data, such as them sending you their blood pressure by using an FDA-defined device, a blood pressure cuff, for example, pulse ox. If they're sending that to you and they're using our app, you can bill for 99457 and the new code 99458, which is significant for those of you in, for example, cardiology who are tracking a lot of these things, and a lot of your patients may already have some sort of device that they can furnish themselves or maybe that you provided to them. Principal care management is really the new kid on the block. And principal care management is, again, CMS's continued attempt to offer reimbursement for non-face-to-face activities. So it's becoming more and more apparent that the goal of value and the sort of construction that CMS has created around value in the quality payment program is facilitated by these remote care codes. Your success in MIPS, your success in an ACO, your success in lowering costs and improving quality can actually be facilitated by adopting a strategy that is aligned with these reimbursements. So principal care management would be a good example where a specialist might be doting on a patient remotely, but also the primary care doctor might be involved. And as many of you know, there was interference between primary care and other specialists in some cases. There could be an attribution to the CPC Plus program, and that patient may not be able to be billed for CCM, or another provider might have been doing CCM. But principal care management allows for that cardiologist, gastroenterologist, or rheumatologist, for example, to dote on disease-specific conditions. And that's why this is defined really as care management to patients with a single complex chronic condition. And they have actually finalized this reimbursement now as well. And there are 2 codes, as we showed it previously. There are 2 types of reimbursements, one for the physician doing all the work, essentially, and one for staff. The following components are required as far as principal care management. I won't read them all off to you. Essentially, what this is getting at is that the conditions required for chronic care management are quite similar to principal care management. And there does need to be a specific disease, specific care plan and adjustments to the medication regimen required. So it's clearly a patient that has significant need for intervention and regular correspondence with their medical practice about their condition. Before we get into an actual demonstration of the product and looking at how this is done, what potential barriers might be and what the potential returns are, I'd like to turn your attention to a study done by an independent party called Karna LLC. Any of you can email me and I'll send you the full study. I figured I would send you just the punchline for now, which is looking at over a 2-year period, hospital admissions for acute myocardial infarction, as well as CHF, congestive heart failure. And the known is that a hospital admission for this disease is about $21,000 over 5 days, and for CHF, about $14,000 over 7 days. And the average hospital readmission is about $9,000 and $9,424 respectively for CHF and AMI. And we can avoid those hospitalizations, which this study showed can occur through surveillance using ChroniccareIQ. There's a very conservative cost avoidance in the sickest cohort from this study. And what it showed you is that by avoiding hospital readmission, that actually $9,424 was saved per patient per year with AMI from that sickest cohort. And for CHF, it was about $9,000 a year. So when you look at the cost of monitoring a patient, this study went on to show you that the cost of monitoring a patient is about $400 a year. That it is very, very well worth the effort when you consider your work in potentially a bundle, or if you're in an ACO or any value-based program where you want to perform and avoid hospital readmissions. And this technology and this approach to remote care, not only does it have remuneration financially available through CMS, but also there is significant push from well-known entities like the CDC, who have engaged us to do a 3-year CDC project on following 3,400 patients with diabetes throughout the state of Georgia. And so these patients are, the goal here for these patients in this particular case is really to get those patients involved in self-management and education, but to improve clinical outcomes as well, to avoid those unplanned hospitalizations and keep their HbA1c at a certain level. Many of you will choose that measure in MIPS, for example, and I know it's hard, along with blood pressure and other things. But what you can see, even during this COVID pandemic and even after it, the new normal, there will be in general an acceptance, I think, by patients and providers that interfacing remotely is extremely valuable in allowing patients to feel engaged with their practices and to do the types of things that lead to lower cost, higher outcomes, and better outcomes. Because these are the things that also CMS has decided that they're going to pay you for, whether it's happening through MIPS and an APM, or you're being incentivized through reimbursements like what we're discussing today. I don't think it's any secret that that is CMS's goal. But the cat is out of the bag, so to speak. Having patients interacted remotely just seems like a foregone conclusion for many of us. So I want to turn the attention now to actually what the workflow looks like. How are these codes achieved? How do you get the billing done? And how do patients interact? And how does the office interact with these patients to make this a easily to attain and operationalize strategy? So I want to turn it over to Matt Ethington, who is the founder and CEO of ChroniccareIQ, and he'll talk about these many different ways to engage patients, how we can meet patients at their comfort level, and how we have success engaging patients, and we get 85 to 93% engagement weekly. So without any further ado, I want to turn it over to Matt and allow him to peel the onion a little bit on what this workflow actually looks like.
Thanks, Brendan. Hello, everyone.
Thank you, Matt.
Yeah, can you hear me?
Yes, I can hear you, Matt. You're good.
Okay. All right. Well, thanks, everyone. Just to summarize in a few short words, what Brendan has just said is that Medicare has a huge expense in chronic patients 2 out of 3 Medicare beneficiaries have 2 or more chronic diseases. Patients with chronic disease are the most expensive and the most prevalent in Medicare. 99% of Medicare's payments are made on behalf of patients with chronic disease, and the CDC will tell you that 7 out of 10 patient deaths are attributed to chronic disease. And we're only halfway through the aging boomer cycle as these folks become Medicare beneficiaries. So there was, even before COVID, there was a huge, huge initiative. I mean, federal laws changed about how do we change our payment infrastructure so that folks, so that we could steer care in the direction of managing chronic disease. It is the problem in medicine. So I'm a chronic patient. I got very sick 20 years ago and immediately switched my career to be in the medical technology business. And I can tell you from the patient perspective, we already know this, managing chronic diseases is difficult. It requires habit-breaking behavior change, but most importantly, it requires a connection with your doctor. And in value-based care models, and when the doctor is being rewarded for the type of care the patient receives based on outcomes, we have to have better communication and connection to patients than quarterly visits, monthly visits, or even biannual visits. So as I think about myself with type 1 diabetes and what it takes to manage it better, what it really means is having a better connection with my doctor. I know that doctors go to school for 10 years to learn how to manage chronic disease. I left the hospital with 2 prescriptions and a pep talk. Right, people that manage chronic disease are managing themselves. So it really becomes, how do we get better engaged with the doctor on one side, and then on the second side, how do we do that in a way that doesn't overwhelm the practice? Everybody in a medical practice is already busy. So we can hold up things like the quadruple aim and everybody likes unicorns and ice cream and puppy dogs. But I remember that's what I thought of when I first heard of the triple aim. But what I'm going to show you is a way to actually achieve it. And Medicare can say things, but where they spend their money is the important thing. And beginning in 2015, they offered $42 per patient per month when you could demonstrate that there was 20 minutes of non-face-to-face activity in the care or coordination of a patient with chronic disease. Since 2015, there's now 15 reimbursements, and they pay up to $265 per patient per month. And it's all about connectivity. It's all about knowing what those patients' blood sugars are, what those heart failure patients' weight is. Have they noticed new swelling? Does this person have tingling in their legs? So we built Chronic Care IQ around something that would proactively engage patients so staff don't have to stop what they're doing, get feedback that's necessary to keep that patient well on key performance indicators like vitals, like observations that they make, like connections that their caregivers may tell you about the patient, but to accumulate and gather responses on patients. What surprised us most was that 87% of patients that start answering questions through Chronic Care IQ are still answering them a year later. There's super high patient retention annually. And it wasn't as big of a surprise to me as it was to everyone else, because we patients, we know we're disconnected. And we can talk to our families and the people that we love and our friends, but it's being connected to your doctor that's the most important thing. So when we get these questions and we make it very easy for patients to receive them, they can get an email, they can get a text, they or their spouse or their child can download an app and the questions just show up on the screen, but patients answer questions. And 85 to 93% of patients engage on a weekly basis. That's another staggering number. The reasons it's so high is because it's simple, right? It pushes them the question, they can look at it and answer it. And it's dynamic. So patients don't get the same questions every day, but when they do answer a question and the system needs a little bit more information, so I put in my blood sugar is really high or my blood pressure and says, hey, wait a minute, did you take your medication today? So the patient side of this is simple. The patients themselves and their caregivers and their family see value in this because it's keeping that doctor updated, which brings the care to the patients. The study that Brendan mentioned was made with Ascension data at a large Ascension hospital here in the South. It showed a 29.8% reduction in 30-day readmission and a 20.3% reduction in all-cause cardiac hospitalizations. It's not because Chronic Care IQ does something magic. There's no therapy inside of Chronic Care IQ. It's closing the communication gap. Because when patients are answering questions regularly, guess what your staff get? Your staff get trends. On this red, yellow, green dashboard, I can immediately see that this patient, Roy Rodriguez, who we're monitoring for heart failure and hypertension, is red alerted. A patient is red alerted when they exceed a clinical threshold or they're trending in the wrong direction. So this really turns that chronic care management into a clinical exercise, not just, hey, did we get this many minutes of care coordination and did we document this much for that pre-cert, et cetera. It really turns it into a vehicle for knowing patients that need you. And while we're monitoring all of these patients and we're collecting time, remember time is the reimbursement vehicle. While we're collecting time on all of these patients, we're managing them by exception. And since we only know their exceptions because we're monitoring all of them, you actually generate about 10 minutes of time for every patient every month just by logging in and looking at this dashboard. And now a staff member can see, wow, there's something really happening that's important here with this patient. And with a single click, we go from having situational awareness of all of our at-risk patients to having actionable intelligence on the ones that need us and why they need us. Now that actionable intelligence turns into prevention. It turns into getting to the patient before they need to be hospitalized, before they go to the ED, et cetera. And it really does groove well with physicians and how they see themselves, right? It's treating a patient after they get out of the hospital. Patient care is always rewarding, but this is the highlight of rewarding, knowing that, wow, we averted this. So it's why it's sticky for patients. It's why it's sticky for doctors. So it's a good early warning system. In fact, I don't know of another. It's a very powerful early warning system. So we get the doctors, we get the providers at hello. Now, where we really start to help the practice on the back end and clinical benefits aside is Medicare has 15 different reimbursements for this, and they're all based on time. Well, that's great. But if I have to document every 1 minute and 45-second phone call and every refill and every pre-cert and all the work that I'm already doing in the chart and all the work, the communication that's already taking place with the patient on the phone, now I'm into not just a clinical exercise, I'm into a document exercise. I'm into an administrative exercise. So what I really like about this platform is it makes it tangible, it makes it valuable for everybody because we plug into the things that you're already doing. For example, to capture time, we have a feature called ChroniccareIQ that plugs into your voice over IP systems. It takes the caller ID log, it throws out the non-clinical extensions in the practice, it throws out the hold time, and it analyzes who's calling, who they're talking to, and how long those calls last. And for that reason, we don't have to create a new exercise for staff and for practices that are participating in Chronic Care IQ. We don't have to create a new documentation exercise. We're gathering it automatically. And so we're getting those phone calls, we're recording those because they're reimbursed with remote patient monitoring. We're getting patient self-reported data, we're getting device data, we're getting data from patients over the phone when we talk to them. We're also getting charting activities. If you've refilled medications, did a pre-cert, pre-authorization, changed medications, medication reconciliation, etc., we're going to grab that. So now the work that's already being performed in the office is captured. And I know a lot of folks initially did things around call centers and, they're going to have a call center so that 20 minutes, we can call a patient for 20 minutes and we'll send a summary of the call and we'll shoot it over to the doctor and they'll be able to reimburse. Well, if you're a patient, that's ridiculous. I don't want to talk to somebody I don't know, and I don't want to talk to somebody 20 minutes a month. I want my doctor to know what's going on a regular basis. So it really didn't move the needle in care, which is why a lot of the Advantage plans dropped out of CCM. And then with remote patient monitoring, I think Medicare pays much more handsomely for that. They kind of woke up. They introduced these reimbursements in 2017, I believe. It's 2019. And they said, look, if you're communicating with your patient and you're spending a lot of online time with them, then that's reimbursable. So when your staff log into that dashboard and they see those patients communicating with you by answering those questions, during COVID, if we have lower visit volumes, that's a great reason to initiate a televisit, which you can do inside of Chronic Care IQ. But it's also time that's well spent because you're checking on that patient. You got another patient touch, and it creates about 10 minutes of monitoring time per month. So we're grabbing all of that time and we're focusing in on those patients that need more care with more frequent patient touches, and patients are very receptive for it. Then we can start doing those, we can start gathering all of those reimbursements and we can show you them. So the neat feature about that is we're centralizing that care activity around proactive outreach to the patient, analyzing their responses, collecting the metrics on the systems that we're using that contribute to reimbursement, and putting them all in one place, and you have a recipe for success with better care. And these care management codes pay handsomely for it. There are a lot of features in here. I would encourage anybody to spend more time with any of us. The clinical results are amazing, and probably one of the most rewarding things I get out of this business is when we get a letter from a patient or a caregiver, and they talk about just making it much more sane for them and really putting good metrics around this. Lots of features we've added since COVID. If you see a patient that looks like they're trending and you need some attention, it's a single click to start a visit for both you and for the patient. So you don't have to invest in extra telemedicine initiatives. We capture that time, we cross-reference it against all of the other time that we're using for the patient to make sure that we're not double billing any time, to protect you with audit logs. We track everything. They're very robust audit logs. What I love for administration, because I have a business to run here also, is the amount of reports that I can get. So they're great reporting features to see who's productive, who's not productive, what patients are missing something, to really dive in and build a great system. And then as far as having patients learning how to use it, that's always the challenge in a practice, right? There's turnover, there's education that's lost, there are things, I've got competing priorities all day long. Well, one of the neat things in Chronic Care IQ is you're managing this patients, and one staff member can manage 400 to 500 patients, and because they're triaging these patients to the nurses. But it gives you a good idea of what you need to do when you click that show button up at the top that I just clicked. It really helps staff to know exactly what they need to do to monitor these patients. It helps doctors understand what's trending with these patients by looking at these graphs. It helps administration understand how are we performing in this initiative through those reports. And by making it easy, by integrating everything into one place and making it easy, that spells out success at scale for practices. Clinical success by averting ED visits and preventing hospitalization, halting disease progression. Financial success, your average reimbursement per doctor per month using Chronic Care IQ is net $5,000 to $8,000. We have some doctors that routinely bill out above $17,000 a piece. Just depends on the amount of population that you want to enroll. So that's protection for the practice. It's, that's getting your arms around it. But it also lowers Medicare costs, as Brendan had pointed out. And it's something that they've been trying to do since the very beginning with the ideas of value-based care, and we're going to make doctors happier and patients happier, and it's going to cost less and it's going to pay the doctors more. Well, we do that because there's so much unnecessary costs in healthcare that you can prevent by having a better connection to your patient. And I will stop talking. I'll talk to any of you until it gets dark if you want to call me. I love the product. I love the results it gets, but I'll stop talking now, Brendan, and I know there's several questions.
Sure, Matt. Thank you very much. Very, very thorough. And I know that there have been a couple of questions. We had one person actually say that they couldn't see the screen, but nobody else has said that. So I want to make sure that one person, if you can just ping me back, let me know that you can see it now. That'll be fine. And I want to make sure that also, if you have additional questions, you know how to ask them. You can simply go up to the very top of the screen on the panel, and you can click on the chat area or ask a question. There's also an opportunity for you to click on your name and actually make your hand raise, and you can ask a question that way by raising your hand if you have a question. Right now, I'm going to let people have a minute to put some questions together. There's one question about CCM and TCM being able to be billed together. We've had this question before as well, and I just will confirm that yes, you can do that now. That previously was not allowed. Maybe you missed the very beginning of the presentation where we did allow that. We just showed that was allowed by CMS now. So if you're doing chronic care management, you can in fact do transitional care management as well.
Brendan, that brings up a point, if I may.
Sure.
So all of you are seeing patients that are discharged from the hospital, and TCM is basically double the cost of an office visit, but you have to document that somebody reached out to the patient within 2 business days and that they were seen within 7 or 14 days. That's a little bit of a death by a thousand cuts things, because when EMRs were built and meaningful use was put in place, they didn't have chronic care management. They didn't have principal care management. They didn't talk about these things. So we aggregated. We can take the ADT feeds from the hospital, and we can show you which of your patients have been admitted, transferred, or discharged. And then we create a countdown timer for your schedulers. So they know that, for example, Carol was discharged 30 minutes ago, and we don't have her complexity yet, that first call or that first appointment. This is an administrative exercise, really. And when you know what it is, and there's a countdown timer screaming at you saying, hey, you have 12 hours left to call this patient, it makes it very easy for a staff member to satisfy those requirements to double that reimbursement. And when it's not a heavy lift and you can put it all together and you can operationalize it, it becomes, that extra $130 here, the $42 that we enrolled that patient for CCM that month, the $64 enrollment fee, the $42 a month. Medicare's really given you a strong vehicle, sustainable vehicle for productive reimbursements to financially get your arms around your practice and clinically get your arms around your patients. The staff just simply, okay, I just made this call and it's documented. And now when that visit happens, it goes into the billing reports. It said, hey, you can bill TCM for this patient. You've got 20 minutes of CCM and you have 40 minutes of RFM. And now all of a sudden, that one patient visit that would have otherwise been, a level 4, $120 reimbursement is a $400 reimbursement, and you've kept that patient from getting readmitted, which would have cost Medicare $9,000. So again, there I go. But happy to talk to any of you about building sustainable strategies to get those reimbursements that you're entitled to, as well as provide that higher level of care.
Excellent, Matt. Thank you. I think that it's worth pointing out, because there was a question that came up of, if you're in an ACO, can you bill for chronic care management services? And the answer is absolutely yes. The scenarios where you would not bill for chronic care management would be around primary care plus, this comprehensive primary care plus organization known as CPC plus APM, as well as the ESRD model for end-stage renal disease and nephrology. Otherwise, you can bill for chronic care management in an ACO. Certainly, getting the billing of $10,000 to $20,000 a month per provider is much better than seeing several patients readmitted where the cost is much higher and the penalty much greater to the ACO. So the focus on moving a patient from a denominator to a numerator and lowering their cost is a significant value-based aspect